Is everybody there? Can you all hear me?
Dr. Ranga?
Yeah, Supun.
Dr. Ranga, mata.
Huh? Hello, Supun.
Dr. Ranga, mage recording allow karana pulawanda?
Oh, allow karamanda.
Hari. Thank you.
The others, are you all okay? Are there any issues with connectivity?
Certain students are having a bit of difficulty, sir, because of the rain and the thunder. But we got 115 at the moment, 116 at the moment.
We'll give about another 5 minutes and we'll start after that. Anyway, we are going to record the lecture, so if there are any issues, people can later access. I will start sharing the screen. So basically, what we are going to do today is a lecture on managing AKI. So unlike last one which I did, which is this one is going to be more like a discussion. So it's a more interactive kind of a session. So what I will do is there are a few cases, and then there'll be questions that that I will put out, and then I will ask you all to indicate which answer that you would want to select. What we'll do is we'll you know that there is a show of hands, so you can raise your hand in the screen if you select a particular answer, so that I know how many has selected a particular answer. We'll try to do that. Okay, I think we have got about close to 130, so I think that's I think fairly good. Okay, let's start. So so case number one, a 47-year-old female is transferred to the medical ICU with fever and reduced level of consciousness. She is a diagnosed patient with type 2 diabetes and hypertension. So it's fairly ill patient. Blood pressure 80/40 with a mean arterial pressure of 53. Heart rate is 126. Temperature is 101. Oxygen saturation is quite okay. Respiratory rate is normal. CVP is around 10. Lung bases are clear. So barely the patient probably is in septic shock, as you know. The issue here is her urine output has been around 10 ml per hour over the preceding 6 hours. Her present treatment include IV antibiotics, insulin, omeprazole, and also she's on a saline drip, 0.9% sodium chloride, 100 ml per hour. So the first question is, which of the following is correct regarding this particular patient? Response A is she has developed AKI. Response B, she has not developed AKI. Response C is there's insufficient information to conclude whether she has developed AKI or not. So anybody for response A, you can raise your hand on the you know, if anybody selects A, you can indicate by raising the hand. It's just to so I think one person. Say default. Anyway, I think second one, response B. Anybody for B? I think it's there are quite a few raising the hand for B. What about C? Ausupun. Oh. Huh? Huh? Ah. Oh. Right. Okay. Yeah. Okay. So the majority feel that the answer is C. There's insufficient information to decide whether this patient has got acute kidney injury or not. But however, if you really look at the case, if you go back, the patient is, you know that the diagnosis of AKI is based on, so what we need to do is find out what the diagnosis of AKI is. So you'd have been taught this during your module lectures. And basically, what you need to know is AKI is defined by either a rise in serum creatinine or a drop in urine output. So you don't have to have a creatinine rise. So based on the urine output itself, you can diagnose AKI. So if the urine output is less than 0.5 milliliter per kilogram per hour for more than 6 hours, then we can diagnose AKI. So if you look at these patients, if you go back, the urine output is 10 milliliter per hour. So for somebody of, you know, roughly, let's say, assume that this patient's weight would be around 50. I mean, obviously the weight is not given, but if you calculate from the possible weight for her to have AKI, so 10 ml per hour is like, you know, if you go by the UK AKI criteria, if she has 0.5 ml per hour, more than 0.5 ml per hour, weight has to be about 20 at least. So obviously her weight is probably would not assume it to be 20 at 47 years of age. So it should be more than 20. So as if it's more than 20 her weight, her urine output is obviously less than 0.5 ml per hour. So this information is, I think, enough to diagnose somebody as having AKI. So this correct answer is she has developed AKI based on the information that we have got, although the creatinine is not available. So so the next question is, which are the most appropriate next step in the management of this patient. So whether you want to increase the currently ongoing saline infusion to 200 ml per hour, which is currently going at 100, or whether you want to give a bolus of saline 500 ml over half an hour and then assess the response, or whether you want to start a norepinephrine infusion because the blood pressure is low, or whether you want to give both fluids plus norepinephrine, or you would want to start a furosemide infusion. What do you want to do? So anybody for response A? Doesn't appear to be anybody. What about B? Three people have raised hands. 4, 5, 6, 7, 8. Okay. 9, 10. What about C? Anybody for C? D? Quite a few feel that about 5 people or 6, 7, 8, 9, 10 people have felt that quite more feel that you will want to give both fluids plus the norepinephrine infusion. Okay, what about E? Anybody for E? Okay, so most people feel either you should give a fluid bolus or you have to give both fluid bolus plus norepinephrine infusion. So let's see what we have to do. So fluid therapy is crucial in managing sepsis. So I think that is the most important step in the managing somebody with septic shock. So you are familiar with the management of sepsis. Usually in the goal is to give lot of fluids during the first 6 hours of presentation. So it's important to do it early rather than worrying about volume. So what and the type of fluid. So you just need to give fluids. It doesn't matter what fluid you give. So but the most important thing is without just giving fluids, you know that the patient's fluid responsiveness is important to judge how much fluid you would want to give. So it's important to give fluids in a certain quantums where a measured volume rather than just giving fluid without any target or any assessment. So if you look at AKI, you know that the initial part, what we call the pre-renal AKI, where the patients are where the kidneys are hypoperfused, and because of that the kidneys are not functionally impaired. The kidney is usually fluid responsive. If you give fluid, the pre-renal AKI recovers and the urine output improves. So this is called the fluid volume responsive stage. But when the AKI persists for some time, you know that there can be permanent damage, or not permanent, there can be structural damage, which is called ATN. And at that stage, the kidney is no longer responsive to fluid. So in other words, if you give fluid, the urine output doesn't go up. Then the excessive volume you are going to give is going to accumulate and cause volume overload. So this is called the volume unresponsive state. So when a patient comes, or when we start treating somebody, we don't really know at which position in this range the patient is in. So this particular patient could be either volume responsive or maybe volume unresponsive. In other words, she may be in pre-renal AKI or she may be already gone into ATA. So therefore, just giving a fluid, just increasing the fluid is not going to work for this patient. So the most important thing is you need to give a particular volume of fluid and see whether the patient improves. So, or whether the patient develops volume overload. So that is the important thing rather than just giving fluid. So how do you find out whether the patient is volume responsive or not? So there are certain parameters that we go by. And there are clinical parameters to judge whether the patient is responding, such as increasing urine output, improvement of blood pressure, reduction in pulse rate, and things like that. But they are very crude. Then you have certain other parameters like central venous pressure, intra-IVC diameter, or pulmonary artery wedge pressure. These are called static parameters. Then in addition to that, there are things called dynamic parameters, where you make a change and then you can assess the response. So these are, I don't think you need to go into detail about these things, but you need to know that there are different types of parameters you can use. But what we commonly use in the ward is central venous pressure. We can just see where it is and then give some fluid and then measure the CVP and see whether the CVP has changed or whether it has gone up or whether it has changed. So based on that, we can decide whether you want to give more fluids or not. So that is what the correct answer is. But actually speaking, static measures like central venous pressure in studies have not really shown that it is associated with any, it's not a very good test to assess the volume status. If here in this particular graph, you see that this side is fluid deficient individuals, this side is fluid overloaded individuals. And if you look at their CVPs across this group, I think there is not much difference between the levels of CVP in the group with the fluid deficient group or fluid overload group. So that's why they say that it's not a very good test. But for our purposes, I think most of us in clinical setup, at least we could use CVP in the management of fluid resuscitation. So therefore, the correct answer in this situation is answer B, where we give a fluid bolus and then assess the patient to see whether there is a response rather than just giving fluids. And still, because the patient's most important thing is to just give fluids in the first few hours, we should not consider giving vasopressors at this stage. So answer D is not correct. So the best answer is B. Then, next question, which of the following fluid is most appropriate in the volume resuscitation of this patient? Is it 0.9% sodium chloride, 4% albumin, ringer lactate solution, hydroxyethyl starch, or a combination of 5% dextrose and half normal saline or 0.45 sodium chloride? Anybody would want to? I told you that at the beginning that it doesn't really matter what fluid you give as long as you give fluid, but out of these three, what would be most appropriate? Could you just yeah, so you can also indicate your answer. Yeah, we'll go by raise of hands. So answer A. Yeah, I think quite a lot feel answer A is the correct answer. Okay, we'll stop there. B, anybody for B? Nobody? Okay. C? So there are quite a lot for C also. Ringer lactate. That's good. And in fact, it's more than for A. Good. What about D? Anybody for D? No. E? Nobody. So here the issue is both A and C are correct. Those are the two types of fluid that we normally give anybody with hypovolemia and low blood pressure. But if you are to select one of the two between A and C, there is increasing evidence that if you look at 0.9% sodium chloride, you only have sodium and chloride in this solution. It is not really a physiological solution because our plasma contains so many other ions apart from sodium and chloride. And if you look at Ringer's lactate solution, it's more closer to what we have in our plasma. So therefore, it's a more physiological solution than 0.9% sodium chloride. In fact, if you read the literature, you see that excessive sodium chloride administration can be associated with hyperchloremic acidosis. So sometimes it can have issues. So, and there is increasing evidence that giving more physiological solutions rather than 0.9% sodium chloride is associated with better outcomes. So, if you are to select between A and C, the correct answer is C. So that is what is the most correct answer in this situation. Okay, right. Now moving on. So we have now given this patient a bolus of fluid. Her blood pressure improves with fluid resuscitation to 100/60. If you remember, initially the pressure was 80/40. Now the mean arterial pressure has gone up to 67 from 53. However, her urine output has not improved. It's still 10 ml per hour. And now the serum creatinine, which we have sent earlier, has come, and it shows a value of 1.6. So obviously, according to the creatinine criteria also, it's supportive of acute kidney injury. Now, other parameters, her heart rate is now 112, we see tachycardic, temperature is slightly, she has slight fever. Now, initially she didn't require any oxygen. Now she has started to develop some oxygen requirement, and she's on 2 liters of oxygen. Respiratory rate has gone up to 22 per minute. Central venous pressure is 14, so it's on the high side. And the lung basis has revealed few crepitations, fine crepitations. So remember this. Now this is how we see what the situation is. Right. Which is the most appropriate next step in the management of this patient? Is it to give another bolus of IV 0.9% sodium chloride and assess the response? Is it to start IV furosemide infusion, 10 milligram per hour? Or is it to restrict fluid intake and observe? Or should we just start on IV noradrenaline infusion? Or should we start the patient on renal replacement therapy? Okay, you get responses. How about A? Anybody for A? Give another fluid bolus. Nobody seems to. Yeah, there's one person. Okay. Anybody for B? Starting a furosemide infusion? Okay, there are about, it's quite a lot, about 15 people, 20. Good. Right. Anybody for C? Just to observe, just not doing anything, just quite few people think that we should just observe without giving any fluid. It's about, again, similar to the response B. How about D? Anybody for D? Starting a noradrenaline infusion? About 4 people, not many. 5, 6. Okay. What about E? Starting renal replacement therapy? 1, 2, 3, 4, 5, 6. Yeah. So yeah, some more people are taking that option. So this is this shows that, you know, this is a very good question. You see, there is a wide distribution or split in the response, because I think at least one person has selected every response. So this is exactly what you want to have in a best of 5 question, where all the answers are correct to a certain degree. It's not that there's 1 out of 5 is correct. You know, all these answers could be correct and maybe considered as a good, as an option in this particular clinical setting, and none of them are wrong. But then there is always this best response. So that is why it's called best of 5. So so obviously we have to select out of these 5 the best response. So if you go by one, the problem with giving another bolus of sodium chloride is already, as I shown you, this patient has developed some fluid overload. Early features, for example, this patient has developed bilateral crepitations. Central venous pressure has gone up. It's on the high side. And also oxygen saturation is starting to drop, suggesting that there's some development of pulmonary edema, and also respiratory rate has gone up. So all these indicate that the patient is starting to develop some fluid overload. So giving more fluid maybe not the ideal thing in this situation. Maybe the patient has now gone into volume unresponsive stage of AKI. So that will be a bit of a concern. And the second response, furosemide infusion, will be good in this situation, because you can get rid of some fluid in this from the lungs. But obviously what you need to understand is, if the patient has developed an acute kidney injury, sometimes they don't respond well to furosemide. Not like somebody with heart failure who has pulmonary edema, where the kidney function is normal. In this situation, there is acute kidney injury, and sometimes there's no guarantee that the furosemide infusion is going to work. So obviously you can try, but it's very unlikely to have an effect in this situation. Then the next one, restrict fluid intake and observe, is not a good response, because obviously the patient is very ill. So you need to do something here. You can't just watch, because the patient is in septic shock and the patient is has gone into AKI and is not clinically getting better. So I think this necessitates some form of action. So obviously you don't want to be watching and waiting. Then initiating renal replacement therapy is a possible option here. And what about the noradrenaline infusion? So if you go by this is a famous depiction of renal autoregulation. You have learned this during your physiology. You know, there's a range of blood pressure, mean arterial pressure, during which the urine or the kidney function or the GFR is kept at a same stable level. So this is called renal autoregulation. So the GFR remains unchanged despite you changing the mean arterial pressure from 80 to 160. So that is called autoregulation. And if the blood pressure falls below 80 or gone above 160, then there are corresponding changes in the GFR. However, in a situation of, this is for a normotensive individual. However, if you develop hypertension, if somebody is with hypertension, these ranges are changed or shifted to the left, to the right rather. So they need a higher blood pressure, mean arterial pressure, to maintain normal GFR or urine output. So if you remember, this particular patient was a hypertensive, if you remember the first slide that I put. And so therefore, even though this patient's blood pressure is looks okay, 100 by 60 with a mean arterial pressure of 67, this may not be adequate to maintain the good renal perfusion. So therefore, the correct answer in this situation, what I would do is to increase the blood pressure. So how do you increase the blood pressure? Is to start an IV noradrenaline infusion. So the answer D is the most appropriate answer for this situation. But I think all the answers are correct to a certain degree. But D is considered the most correct answer. Okay. Right. So moving on. So despite initiation of IV noradrenaline infusion, her urine output remains low. So now we have given fluids, and now we have started noradrenaline infusion. Now if you see now the blood pressure has gone up from 100 by 60 to 125 by 70 now. So roughly this is mean arterial pressure is now close to 100. So even with that, the urine output has not improved. And the heart rate has gone up, respiratory rate is slightly improved. Oxygen saturation is still okay with 2 liters of oxygen. Lung bases having crepitation. Now the creatinine has gone up to 2. Blood urea is 82. And the most striking here is now the potassium has gone up to 7. So this is a medical emergency. Now this patient's potassium has gone up to 7. And the pH is, they have done a blood gas, pH is 7.36 with a bicarb of 80. Okay, so the next question. What is the best next step to reduce serum potassium in this patient? So In other words, rather than best next step, you can say the best step to reduce serum potassium. So obviously all these treatments are used to reduce potassium. What I would want to know is what is the step, that immediate step that you would take here, the first step to reduce potassium in this patient. Is it IV calcium, giving IV calcium gluconate, giving IV sodium bicarbonate, giving start insulin dextrose, start a potassium binding resin, or initiate renal replacement therapy? Anybody for A? There are about 10 people. 12, 15, okay. We stop there. How about B? Giving sodium bicarbonate. By the way, you're supposed to select only one response, right? I'm not, I can't make a, recognize how many, the same person is indicating for more than one answer. So you have to make sure that you indicate your response only to one particular answer, right? So answer B, some have considered that. How about C? Right, quite a lot have selected C. About 25 people. Good. How about D? Okay, few people have selected D. E? Right, so again, about 15 people have selected E. So again, you see that a lot of people, there's a good split of response here. So that means all these responses are correct. But what you need to realize is there's always one best answer. So if you go by each of these, obviously what you need is a catch question response here. That is response A, because you know that the question I have asked is which treatment, the treatment that is going to reduce serum potassium. So calcium gluconate actually is a drug that we give in hyperkalemic emergencies, but it is not to reduce potassium. It is to stabilize the cardiac muscle membrane, so that the erythmogenic potential of hyperkalemia is diminished. So that is why you give calcium gluconate. It's not to reduce potassium. So therefore, A is a wrong response. It's given just to catch you off guard, because you might just in a rush make mistakes like that if you don't read the question properly. Then the answer B, sodium bicarbonate is also used in patients with hyperkalemia to bring down the potassium, but it usually works well for people who have acidosis. Now here, if you look at this patient's blood gas, she doesn't have much serum metabolic acidosis. She has a pH of 7.36 and bicarbonate is low. I agree it's low, but it's not very low. So here the effect of sodium bicarbonate correcting the potassium, which be not great. Then insulin dextrose is the correct answer here. So this is the best treatment, the next option to reduce potassium. Potassium binding resin is actually will take some time, because it is intended to bind to the potassium in the food, in the gut, so that further absorption of potassium into the system will be reduced. However, the already elevated high potassium will not be reduced by starting a potassium binding resin. So it generally takes about 24 to 48 hours to start working. So it is not ideal for emergency. And initiating renal replacement therapy is also an option, because obviously this patient has now really getting worse. Her renal output, urine output is persistently low. She's getting features of fluid overload, and she's starting to get hyperkalemia. But however, still there's no strict indication for us to start dialysis, because we haven't tried to manage potassium medically. So first we will treat with medical potassium, management, and then if it doesn't work, we will go for renal replacement therapy. But I think now this patient is increasingly starting to look like as if she is going to need renal replacement therapy. So So E is becoming imminent, but still I think the correct answer is D. Sorry, not D, sorry, C. Right, so moving on. 12 hours later, after 2 doses of insulin dextrose, her urine output remains low at 10 to 15 ml per hour. Her clinical and lab parameters are as follows. The blood pressure is remains stable like last time. The weight is also stable. She still has few crepitations in the lungs. Creatinine is going up still further. Now it's gone to 2.8. Potassium has somewhat improved, but still 6.1. And her pH has started to drop 7.3 with a bicarb of 60. So slightly dropped. Now the next question. What is the best next step in the management of this patient now at this point? Should we just increase the furosemide dose? Should we add some metolazone to this patient? Because assuming that the patient has already got some furosemide because of the pulmonary edema. Should we give IV sodium bicarbonate to this patient? Should we repeat another insulin dextrose because potassium is 6.1? Or should we initiate renal replacement therapy? Anybody for A? B? So obviously nobody is thinking that we should be giving a lot of diuretics in this patient. What about C? Okay, so quite a lot feel that because patient is now developing more and more acidosis, bicarbonate is a good option because it will correct the potassium also. So that is, there were 20 people who have gone for that. How about giving another dose of insulin dextrose? 2 people, so 3. Yeah. Anybody for E? Right. Quite a lot have selected E. I think about 40-50 people. Yeah. So if you analyze this patient, as I told you in the previous scenario also, the patient is getting worse. Clearly the renal injury is not getting better. Her urine output is not improving. And on top of that, she's gradually getting fluid overload. She's becoming more and more acidotic. And her potassium, although it has improved somewhat, it is still quite high. So clearly there is more than one issue here. There is accumulating fluid with fluid overload and worsening acidosis, persistent hyperkalemia. So just trying to correct one of these individually is not going to be the ideal. I think now we have reached a situation where we need to consider renal replacement therapy, and that is the correct answer. So so if you look at the literature, there's increasing evidence that fluid accumulation, in addition to the other complications that that I described in this patient, fluid accumulation itself, even without developing pulmonary edema and other features of acute fluid overload, even just the accumulation of fluid or increase in weight. If you remember, this patient's weight has gone up by about 12 kilograms by this point, because we were administering a lot of fluid and the patient was unable to excrete these extra fluid. So what the studies have shown is just the accumulation of fluid itself is bad, and it's associated with poor survival. So these are some of the studies where so this top graph shows at the initiation of renal replacement therapy, they have compared individuals with fluid overload and without fluid overload, and people who have had fluid overload at the time of initiating renal replacement therapy, the cumulative survival has been poor. So they have done worse than people with no fluid overload. And similarly, at the acute diagnosis of acute kidney injury, if there had been fluid overload, they also did worse. So, so therefore, I think there's enough and more reasons at this point to start the patient on renal replacement therapy. So I was trying to highlight in this particular case how you start, how the case evolves, and different options of management become the most appropriate step at different points of time in the same case. So it's a dynamic situation. So managing patients with who are critically ill, especially in sepsis and AKI, is not a static situation, and that means you need to be involved in the care of the patient, needing close monitoring of the patient, so that at each time point that the best management option can be different. So this highlights in one single case how various treatment options become most appropriate at different time points. So I think that's what I wanted to highlight in this particular case. Okay, so the next part of my lecture is on few more case scenarios in relation to acute kidney injury, and where we have to identify several therapeutic issues. So anybody who wants to ask any questions up to this point can now ask. I think there are a few questions here. I'll just go through them. Yeah, some of them actually are right related to responses, why one response is better than the other. I think we have moved on, so I can't really trace back which response are we talking about. What is the best method of dialysis in obese patient? Is hemodialysis or peritoneal dialysis? Although it's not really quite relevant to what we have discussed so far, in obese patients, hemodialysis is better because peritoneal dialysis, especially when we are obese, it's difficult to manage fluid. But the thing is, it doesn't really. There's no major difference. Even in obese people, you can do good peritoneal dialysis. Any other questions? Okay, you can go on asking. Yeah, can we use colloids in AKI? Colloids are not really used for AKI treatment. It's just to manage the hypovolemia and hypovolemic or septic shock. But there's no evidence that using colloids over crystalloids is associated with better outcomes. And there can be a few issues with using colloids, such as these HETA starch preparations interfering with the cross matching and blood cross matching and things like that. But so there's no advantage of colloids. So is there a cutoff potassium value for renal replacement therapy? No, it's basically generally what you need to consider is whether there is a life-threatening elevation of potassium, which is not responding to medical management. So usually what we go by is if there is potassium above 7, which is not improving with medical management, I think that's an indication. And also if there are ECG changes and the likely cause for the hyperkalemia is going to persist despite the medical management, I think no point in giving medical management, because as you know, medical management is just a bridge therapy to something more kind of effective. Because if the cause for the hyperkalemia is still persisting, it's very unlikely to get better just with medical management. Since the patient is already on insulin for diabetes, how should we titrate insulin and dextrose to treat the hyperkalemia? Yeah, so in patients who are hyperglycemic, you don't have to give dextrose. You can just give insulin, because dextrose is given to prevent to minimize the hypoglycemic effect of insulin. Because as you know, in a normal person who is not a diabetic, once you give insulin alone to bring the potassium down, obviously the insulin will reduce the sugar levels also, and the patient can become hypoglycemic. So in a diabetic patient, the sugar levels are not normal. They are usually high, but even in diabetic patients, sometimes because they are already on treatment, their sugar levels may be normal. So in that situation, you have to combine dextrose with insulin, because otherwise the patient will end up with hypoglycemia. So I agree that you have to look at the present glycemic level and then decide whether you want to add dextrose or not in a diabetic patient. Then there's another question. Sir, can't the reduced urine output be due to shock without AKI? Yeah, that's a nice question. Actually, the AKI is based on creatinine or urine output. You don't have to worry about the cause for the AKI. So if somebody, I agree that the shock is the reason, could be the reason for the AKI, because the low blood pressure, you have reduced renal perfusion, and because of that, there's no urine coming out. But still, it is AKI because there is no urine output. So we don't need to worry about the cause for the reduced urine output. What we need to know is if there's reduced urine output, that is AKI. So don't worry about the cause. Yeah, I think there are quite a lot of questions about insulin and dextrose and various things, but I think we need to move on. We'll try to answer some of them if we have time at the end, because we have to just finish some more cases. Okay, moving on. So case number 2. A 45-year-old male with diabetes and ischemic heart disease is admitted with a non-STEMI, non-ST elevation myocardial infarction. An urgent coronary angiogram is planned. Her serum creatinine comes as 1.5 milligrams per deciliter. Normal range is 1 to 1.3. EGFR is 50. So she has probably underlying chronic kidney disease. What is the best method to reduce contrast nephrotoxicity in this patient? Is it not to perform the coronary angiogram, or to encourage him to drink fluid before the procedure, or to start him on IV 0.9% sodium chloride 6 to 12 hours before the procedure and to continue for another 6 to 12 hours after the procedure, or start oral N-acetylcysteine for 48 hours, or to discontinue metformin 48 hours before the procedure? Okay, anybody for A? B? C? Yeah, so quite a lot of people have selected C. Okay, stop. D? Nobody. Okay. E? Yeah, so most of you have thought that the giving fluids is the most important thing, and that is the correct answer. And it is IV fluids, not oral fluids. So the oral, just asking the patient to drink more fluids is not going to make a difference. And oral N-acetylcysteine or any other drug for that matter has not been proven to be beneficial in preventing contrast nephrotoxicity. So the correct answer is C. And you need to have some idea about the degree of risk of contrast-induced nephropathy depending on the GFR. So there are several risk factors for developing contrast-induced nephropathy, and the most important of those is presence of pre-existing CKD. So they are at the highest risk. So if the EGFR is more than 60, then you don't have any issue with giving contrast. There is no prevention strategy required because the risk of contrast-induced nephropathy is very low. But if the EGFR is between 45 to 60, there is a low risk of developing contrast-induced nephropathy, especially for intra-arterial contrast procedures. But intravenous contrast procedures usually are safe. But if the EGFR is less than 45, then the risk is higher, and even for IV contrast, you need prophylaxis. Okay, the next case. A 46-year-old female with diabetes and hypertension and ischemic heart disease presents with dysuria, loin pain, and fever. Her UFR shows field full of pus cells and a provisional diagnosis UTI is made. She started on intravenous antibiotics and her symptoms improved. So basically she's being treated for a urine infection with antibiotics. On admission, her serum creatinine is at 0.9 milligrams per deciliter. By day 3, her serum creatinine increases to 3.1. Her urine output remains normal. Okay. What is the likely cause for her AKI? Is it pyelonephritis? Is it glomerulonephritis? Is it obstructive uropathy? Or is it some other cause? Anybody for A? Okay, quite a lot. B, do you think there's a glomerulonephritis going on? C, obstructive uropathy. How about some other cause? Yeah, so that's the correct answer. And what is this other cause? That is because this patient is probably on a lot of medications, and we have to think somebody, especially who's hospitalized on treatment with various drugs. Always we have to cut. And that patient develops acute kidney injury, always you have to think of a drug-induced acute kidney injury, and that's the most important consideration you have to make here. Because pyelonephritis is getting better in this patient, so it's unlikely to be the cause for an acute kidney injury. Of course, you know that acute kidney injury can be caused by pyelonephritis, but if somebody is getting better, as in this case, it's unlikely to cause acute kidney injury. So glomerulonephritis is, not relevant here because there's no evidence of glomerulonephritis in this patient. Obstructive uropathy also, there's no information given, so it's cannot be considered. So drugs, so you need to know the drugs which can cause acute kidney injury, because always you have to look at the drug charts of these patients to see whether they are on any drug which can cause acute kidney injury, such as antibiotics, non-steroidal anti-inflammatory drugs, proton pump inhibitors rarely can cause acute kidney injury. Allopurinol, ACE inhibitors, angiotensin receptor blockers, diuretics, statins. So a lot of drugs are there which can give rise to acute kidney injury. So you need to go through the drug charts of these patients to find out whether they are on any nephrotoxic medications. Case number 4. So it's about a drug-induced acute kidney injury. A 54-year-old male, a 54-year-old female is treated for culture-positive UTI with IV amikacin 375 milligrams twice daily. Her serum creatinine, which was normal, on admission, returns at 2.1 milligrams per deciliter on day 7. Aminoglycoside-induced nephrotoxicity is suspected. What is the most appropriate next step in the management of this patient? So this patient is being treated for a urine infection and on IV amikacin, and the patient has been on this drug for 7 days, and the patient's creatinine, which was normal on admission, has suddenly been found to be elevated on day 7, because you don't normally do creatinine frequently sometimes in these patients, and suddenly you do a creatinine because you know that aminoglycosides can cause nephrotoxicity, and you suddenly get a shock when you see that it's gone up. So what's the best step? So next step in the management. So whether you want to discontinue amikacin and change to an alternative antibiotic, or you want to continue amikacin at half the dose twice daily, or you want to change the dose but half dose, but give it once daily. or you want to check the blood amikacin level and change the dose only if the levels are in the toxic range. You know that you can check the blood levels of amikacin, or whether you want to continue amikacin without any change in dose, since aminoglycoside nephrotoxicity is unlikely in this patient. So you need to know about a little bit about aminoglycoside nephrotoxicity. So anybody for A? Yeah, okay. I think majority of you feel that it's A is the correct answer. B, you can continue the dose but at a reduced dose, but giving twice daily. C, as a once daily dose. D, few. E, one person. Okay, so you need to know a bit about aminoglycoside nephrotoxicity. So correct answer here is A. I will tell you why. So usually aminoglycoside nephrotoxicity occurs in about 5 to 7 days after the initiation of the drug. So if somebody started on aminoglycoside and you get a creatinine elevation by day 2 or day 3, it is very unlikely to be the reason. The cause for the AKI is due to aminoglycoside. It takes about a week. So the first the response E here is wrong, because the patient has actually had sufficient exposure of amikacin. He has gone to day 7, so therefore it is likely that this patient could be having aminoglycoside nephrotoxicity. Then about the dose, just because somebody has got nephrotoxicity doesn't mean, or AKI doesn't mean that you cannot use aminoglycoside. So most people think that aminoglycosides are nephrotoxic, therefore you can't use aminoglycosides in patients with AKI. That is wrong. There is always a dose adjustment for any patient. Even though the drug can cause acute kidney injury, sometimes you can use dose adjustment to reduce, to give the drug at a reduced dose for certain conditions. But here what is important to realize is the most likely cause for the AKI is aminoglycoside. So it's not like you are trying to use aminoglycoside in a patient with reduced GFR. The cause for the reduced GFR is aminoglycoside. So in this situation, it is not appropriate to continue the drug if you have the option of using another alternative antibiotic which is non-nephrotoxic. You should actually stop the amikacin. But sometimes there are situations where even though the amikacin is the likely cause for the AKI, you can't take the patient off amikacin because that is the only drug that the patient is sensitive to. So in that situation, you have to use amikacin using a reduced dose. And it has been shown that amikacin, if you remember your pharmacology, amikacin or the aminoglycoside group is cause antimicrobial killing. It's a concentration dependent killing. So in other words, it's the peak concentration of the aminoglycoside which matters with the bactericidal activity. So even if you give the same dose as a single dose, or break it down to 3 doses and give it over the day, what matters is what is the peak concentration achieved. So it has been shown that by giving amikacin as a single dose, the nephrotoxic effect can be minimized. So because it's a concentration dependent drug and you can minimize nephrotoxicity by giving it as a single dose, mostly we recommend that the aminoglycosides should be given in patients for treating infections as a single daily dose. So the entire dose per weight can be given as a single daily dose because it will minimize the effects on the kidney. Why this happens, I'm not going to tell you. You can read if you are interested. So therefore, if you are to continue the drug, with a reduced dose, I think out of the B and C, then you have to go for B and C. In that situation, C is the correct answer compared to B. But however, in this situation, we assume that there is an alternative medication, antibiotic that is patients could be used. So A is the best answer. Then amikacin level, checking the amikacin level in patients with nephrotoxicity is not useful because nephrotoxicity does not correlate with the aminoglycoside level in the blood. So therefore, you can't go by the level to decide whether the AKI is caused by amikacin or not. So therefore, D is also incorrect. So therefore, the correct answer is A. So you need to change the antibiotic to a different antibiotic. Yeah, so this is about aminoglycoside nephrotoxicity. So the same thing I have told you. Yeah, so you need to know certain risk factors for developing ATN in aminoglycosides. Advanced age, superimposed sepsis, liver disease, hypertension. So these are some of the risk factors. Yeah, the last case. A 75-year-old is brought to the emergency after being found unconscious in his bed. CT brain shows a large ICH associated with cerebral edema. He started on IV dexamethasone mannitol. On day 3, his creatinine returns at 2.8. So somebody has come with ICH and found to have a high creatinine. What is the likely cause? Is it dehydration, dexamethasone, mannitol, or some other cause? Anybody for A? B? C? D? Okay, so majority feel that it's due to mannitol, and that is the correct answer. Yeah, so dehydration is a common cause for AKI in patients who are in ICU, especially who are having problems with cerebral problems, who are unconscious, because as you know, we all have a thirst mechanism. So when we have we are reduced increase in osmolality or dehydration, we always can take water. But if somebody is unconscious, then you don't have access to water. You can't take water. So they are at a higher chance of developing dehydration. However, this patient is managed in ICU, so it's very unlikely that somebody can become dehydrated while the patient is being looked after in ICU. So therefore, A is probably wrong, but it happens sometimes, especially if you don't look after patients properly. Dexamethasone is not a cause for AKI; it's actually a treatment for AKI. So it's a steroid, so it doesn't usually cause acute kidney injury. Mannitol is the cause in this patient for AKI because mannitol is a hyperosmolar substance. It is actually can be used sometimes as a osmotic diuretic, and so therefore it can be used in patients with cerebral edema as a treatment, and especially in patients with pre-existing renal impairment, you have to be careful in using mannitol because that can cause renal injury. And you can cause the cause for the renal injury. There can be various mechanisms. One is renal vasoconstriction, and sometimes these mannitol residues can be taken up by the proximal convoluted tubules in the kidney, in the nephron, and that can cause acute tubular injury. So you can still use mannitol in patients, but you have to be careful. You can restrict the dose to less than 1.5 grams per kilogram per day, and you can limit the duration of the exposure by reducing it to for 24 to 48 hours rather than continuing it. and especially patients who have already developed AKI, sometimes you can use mannitol combined with dialysis to remove mannitol, because mannitol can be removed with dialysis. Okay. Yeah, I think that is it. So I can answer a few questions if you have anything, because there are so many scenarios that you can get with acute kidney injury. Which it's difficult to discuss all the therapeutic aspects of all these acute AKI scenarios. The commonest is the sepsis scenario, which is the one that I discussed with you in detail, and then I discussed few other scenarios as well. Yeah, so any questions? Yeah, in case 3, women with pyelonephritis, diabetes hypertension, do we know which drug cause AKI? She is on several drugs causing AKI. In that case, do we withdraw drugs? Yeah, so that's an important question. If there are many drugs which can cause AKI in a particular patient, which drug, we don't know which drug is the likely cause, and how to decide the drug which is causing the AKI. So you can take several you can approach it in several ways. One thing is, if all the drugs which can cause acute kidney injury in that patient could be changed to a different drug, the best option is to change everything. So then you are sure that we have removed all the drugs. But then there are more nephrotoxic. If you can't do that, then there can be more nephrotoxic drugs than the others. For example, if somebody is on a non-steroidal anti-inflammatory drug, you know that definitely it is the most likely cause, because it's the one which is most associated with acute kidney. So you can stop that and see. So there's no hard and fast answer for that question. So you have to take it as it comes and decide depending on each individual case. Yeah, if nephrotoxicity doesn't depend on the aminoglycoside level in blood, do we always proceed with discontinuing? No. Now, what I said was that aminoglycoside level, sometimes it does not correlate with whether the patient develops nephrotoxicity or not. Sometimes even with a low trough level of aminoglycoside, still you can have AKI. And sometimes even with a higher aminoglycoside level, the patient may not develop AKI. So what I wanted to highlight is, sometimes just going by the levels alone, you can't decide whether the AKI is caused by aminoglycoside or not. But we are sure if somebody with aminoglycoside, if they develop AKI, is most likely that is the likely cause. Is glycosuria an indication to start anti-diabetic drugs in CKD? I think I have answered this question. Glycosuria is not an indication, because it just shows, it indicates that the tubular reabsorption of glucose is defective. So that it just tells you glycosuria can be a cause of hyperglycemia also. But in the absence of hyperglycemia, if you just have glycosuria, that is not an indication to start anti-diabetic treatment, because the patient is not a diabetic. Is there a national guideline for CKD and AKI which we can read? National guideline for CKD or AKI, I think that's what you're asking. Unfortunately, there's no guideline for AKI in Sri Lanka, national guideline, but there are some guidelines in the ministry for management of CKD. So, and especially for CKDU, actually these guidelines were developed mainly for CKDU management, because the ministry is very interested about managing CKDU. So, so that is the answer for that question. Then the next one. What is the usual protein loss? What is this? No, You all are drawing on the screen. I can't read what is. What is the usual protein loss in CKD? I think that's what the C. Yeah. So it's not very clear what the question is. What I assume is that to diagnose CKD, or I don't know what is meant. What is the usual protein loss in CKD? Can you just be more clearer in your question? The person who has asked that question, can you just give more specific, be more specific in that question? The next question is, are there any specific set of criteria to initiate renal replacement therapy? No. Usually there are very specific criteria to diagnose, to start renal replacement therapy, especially if there are life-threatening situations, like for example, refractory hyperkalemia to medical management, refractory acidosis, refractory fluid overload, or pulmonary edema, or uremic encephalopathy. Those are absolute indications. So there we have to start on the renal replacement therapy. But obviously, you don't wait till you develop those absolute indications. You want to start renal replacement therapy to prevent these complications. So life-threatening indications are there, but those are not the only indications where we start renal replacement therapy. Yeah, I think we'll stop there. Just give me a minute. Yeah, so so we'll have the next session on Tuesday on UTI, management of UTI. So we'll do that as another interactive kind of a question-based session. Okay, thank you very much. Okay.